endocrine disorders. Again, a reminder, normal anatomy and physiology. There's a figure on page 872 that shows the site of all the endocrine organs, and there's a table that lists on page 873 what the pancreas secretes. The islets of Langerhans has 4 types of cells. You have your alpha cells that produce glucagon, your beta cells that produce insulin and decrease your fat stores, your delta cells that produce somatostatin, which also lowers your blood sugar, lowers your glucagon, and decreases the amount of insulin that you have. Now, in the last edition, the pancreatic polypeptide cells, they said they didn't know what they did. Now they do. They stimulate gallbladder contraction, and they decrease pancreatic enzyme release. Insulin is also secreted by the beta cells, and it lowers your blood sugar, decreases mobilization of fats, increases potassium into the cells, movement into the cells, and stimulates protein synthesis. And there's a box on page 874 that deals with this. Insulin is not required for transport of glucose into the brain. Glucagon will raise your blood sugar levels, and there's a box that talks about glucagon on page 874. And as I said, your somatostatin decreases your insulin release and decreases your glucagon release. So that's good most of the time. Your hypothalamus has releasing factors for all of many of your hormones. It also produces ADH and oxytocin. Your anterior pituitary releases ACTH and TSH, and your follicular stimulating hormone, your luteinizing hormone, your growth hormone, and prolactin. Your posterior pituitary releases antidiuretic hormone, which is what's stored there, and ADH constricts smooth muscle and maintains the osmolality of the blood. There's a figure on 875 and a box on page 877 that talk about the factors that affect ADH release. And the physiology of ADH release is found on page 876. Your thyroid gland, there's page 879 has a table for the function of the thyroid. It releases T3 and T4, which together is your thyroid hormone, and calcitonin. And calcitonin decreases calcium release, calcium levels. Your endocrine system, your pancreas, there's a box on page 883 of what to assess. And you're going to check your blood work, your fasting blood sugar, your hemoglobin A1C, and your hemoglobin 1C. And you want the normal for that to be between 4 and 6. There's a table on page 884 that lists the values and compares them with blood sugars for your hemoglobin 1C and A1C. Your pituitary gland, you're going to assess the hydration status because it's responsible for your ADH. So you're going to do a serum ADH, a urine and blood osmolality, and a water deprivation test. A CT scan, MRI, and skull series also will help to see the pituitary gland because it's in the brain. Your thyroid studies, there's a box on page 886 for the history of the questions you're going to ask. The testing you'll do is on page 887. The drugs that influence thyroid function are on page 888. And the endocrine system's response to stress is found on page 893 in a table, and you'll want to read that. The adrenal gland causes of Cushing's syndrome. You see a table on page 889, and the symptoms of pheochromocytoma are on page 889 also. Diabetes is becoming epidemic. There is a box on page 913 that lists the symptoms for both hyper and hypoglycemia. If you're a type 1 diabetic ketoacidosis is your primary major complication. There's a box or on page 907 you'll have the concept map, and on page 908 you'll have a box that has the patho for that. And the types of insulin you use will be in a table on page 899. Management of DKA, every hour blood sugar, urine-specific gravity every 2 hours, CVP, BUN, creatinine. When your blood sugar drops to 200, you're going to change to D5 and normal saline with the insulin drip rather than just plain saline to give them a little bit of glucose. You're going to lower that potassium within the first 4 hours by giving them the insulin. So you have to keep a close eye on your potassium. There's a protocol that you'll follow, and that's on page 910. If they give Lispro, it has an onset in 10 minutes, peaks in 60 minutes, and lasts about 3.5 hours. Lantus is more long-acting, and you take that at bedtime. Nursing diagnosis you'll find on page 911 and patient teaching on page 913. HHNKS is the old term for hyperosmolar hyperglycemic non-ketotic syndrome. Now they just call it HHS, hyperosmolar hyperglycemic syndrome. I like the old phrase because it told you exactly what to look for. This occurs with your type 2 diabetics, and it tells you that they will not have any ketones, and that's because the body still produces some insulin. In fact, they call it, instead of syndrome, it's now called a state, a hyperosmolar hyperglycemic state. The patho is found on page 917. Your usual meds are on page 903 to 905. Your treatment flow chart is in a box on page 918. Treatment is something to measure their hydration status, either a central venous pressure line or pulmonary artery catheter that does pulmonary occlusive pressures, or wedge pressures. Your hydration, your neurostatus, you need to check your electrolytes every 2 hours and check your blood sugar at least every 30 minutes. And do blood gases because they will be severely dehydrated and they will be in acidosis, so you need to check that. Your comparison with DKA we will find in a box on page 916. Your nursing diagnoses on page 918. And the concept map for this on page 915. Evidence-based practice on page 920. Diabetes insipidus, you'll have a decrease in your ADH. So the patient will be very, very thirsty, and they'll have a very, very large urinary output. There are different causes for it. There's a box on page 920 that lists them. There are 3 different types: central, nephrogenic, or psychogenic. There's a figure on page 922 that gives you your different types. Your nephrogenic can be caused by lithium, so your patients that are manic depressive could develop some nephrogenic diabetes insipidus. But it will lead to hydronephrosis, a decrease in your specific gravity, a decrease in your urine osmolality, hypotension, polydipsia, tachycardia, shock, and electrolyte imbalances. The hypernatremia causes restlessness, agitation, a decrease in your reflexes, and seizures. Your lab values are on page 923. Your nursing diagnoses and your patient education is on page 924. Central you'll see occurring, it's just sometimes called neurogenic, following any type of brain surgery, oftentimes following other surgeries that may affect the amount of ADH that's put out. The other thing is psychogenic. I took care of a guy that had psychogenic DI once, and he was admitted to my unit because we didn't know what his problem was. He was very pale, he was hyponatremic, and he was having huge amounts of urinary output. Come to find out, he was having huge amounts of oral intake, too. He was practically drinking out of the faucet. And when I went in to assess him one morning, I asked him, why are you drinking so much liquid? Because I was just kind of curious, and I thought, well, I might as well just ask him. And he said, well, it's because he told me to. And I said, he told you to? And he said, yeah, that guy over there in the corner. And I looked, and there was no guy in the corner. And I said, oh, and how long has he been telling you to do this? He said, oh, for the last couple weeks. And I said, he told you stuff to do before that? He said, no, I've only seen him for like the last couple weeks. And I said, okay. And I went out and I called his physician and I said, I know what's wrong with your gentleman. He's on the wrong unit. he needs to go to the psychiatric unit. And I told him why, and he said, that's a really good idea. Call the psychiatrist and have him evaluated. But that was the only time I ever dealt with somebody who had psychogenic DI. It does not occur that often. But his color was actually pasty. He had practically no color at all. Nice man. The medical treatment you'll find on page 923. The meds that are used are vasopressin, your hypotonic fluids. Your patient will be on INO, daily weight. They're at risk for hypertension and overhydration. Your nursing care, fluid status, INO, daily weight, risk for constipation, and a risk for diarrhea with the vasopressin treatment. So you need to make sure they get adequate fluids, adequate fiber, and stool softeners, because the fiber will help prevent the diarrhea and will help with the constipation also. SIADH is the syndrome of inappropriate ADH, antidiuretic hormone. With this syndrome, it reabsorbs water and continues to dump sodium. Page 925 has a list of the causes, and there's a figure on 926 that shows the pathophys. But your symptoms are a decrease in urinary output, an increase in urine sodium, an increase in blood volume, an increase in your hypoosmolality, so you're going to be very low osmolality, anorexia, nausea, vomiting, irritability, confusion, seizures, and possibly even weight gain, depending on how long this goes on for. Treatment, you want to limit their fluids to 500 milliliters a day. You weigh them every 12 hours. If their sodium is less than 115, you're going to give 3% saline. And that will raise your sodium levels 12 milliequivalents per day over a 48-hour time frame. And you infuse it at 1 milliliter per kilogram per hour, because you do not want to send this patient into heart failure. You need to increase that CVP and your pulmonary capillary wedge pressure, or occlusive pressure. Lasix, 1 to 2 milligrams per kilogram per hour may be given. If the cause is cancer, treat them with lithium and tetracycline. You're going to assess your neurostatus every 2 hours, particularly for your level of consciousness. If they're constipated, you cannot use a hypotonic or tap water enema, because the fluid of the enema will be reabsorbed. Nursing diagnoses you'll find on page 927. A thyrotoxic crisis or thyroid storm. There are boxes listed on page 928 for these conditions that are associated with thyroid storm or precipitating thyroid storm. Symptoms are in a box on page 929. Medical treatment is on page 931. But they need to lower that T3, T4 within 24 to 48 hours. You lower the fever with a cooling blanket and fluids. You do not give them aspirin, because aspirin binds with protein, releasing more thyroid into the system. So you use a cooling blanket and fluids. You treat the cause. Propofol, uracil, and tapazole decrease the synthesis of your thyroid hormone. Dexamethasone, saturated solution of potassium iodide, and potassium iodide decrease the release of the thyroid hormone. Your beta blockers, your alpha blockers, and your calcium channel blockers treat your symptomatology. Your nursing diagnoses and patient education are found on page 930. Nursing care, you'll be doing a temperature every 15 minutes, because they'll be extremely hyperthermic. You need to lower that fever, again, with a cooling blanket, not with aspirin. Hydration, very important. They need to have their fluid status closely monitored. So at least a CVP, if not a PA catheter, in which you can do cardiac outputs. Myxedemic coma is the major complication of hypothyroidism. There's a box on page 933 that lists your signs and symptoms. They'll have severe constipation, hypotension, carbon dioxide retention, respiratory acidosis, and arrest are possibilities, because that tongue gets really thick, and so they may have airway obstruction. Hypothermia. Hypothermia, they need to be rewarmed slowly, because otherwise they can go into shock. Your nursing diagnoses you'll find on page 934, and your patient education is on page 935. And that finishes